Hello and welcome to the third episode of The Art of Drug Choice. This is treating new wet AMD patients. And in this episode, we'll be discussing how to treat a new patient and forecasting how their treatment decision tree may change in the near future. So we have our esteemed faculty, Dr. Lejla Vajzovic, as well as Dr. Joe Coney for this episode again. So Lejla, I'm going to start with you. We talk a lot about new treatment options, brolucizumab, approval of port delivery system, as well as upcoming approval of possibly faricimab. But let's go back a little bit. Treating new wet AMD patients, what was the paradigm before aflibercept was approved in November of 2011, and how that paradigm has changed over the last decade? And then we can talk about how it's going to change with the new treatments.
That's a great question to kind of contrast that. And, thinking about it, paradigm is about the same, except we have more drug choices. I would still start with bevacizumab. And I think that's just an easy start that's efficacious. And for somebody who's just stepping in the clinic with no known diagnosis, I find it challenging to get approvals for branded drugs. And being that I practice in a university setting, I actually also do not have access to samples. So I will definitely start with bevacizumab and give them a kind of 3 injections a month apart to get a loading dose in and see how they respond. And based on that response, I may very likely continue that route or switch them to a branded drug at that point. So that paradigm has not really changed for me that much. But I'm excited to have longer treatment options and potentially change with that, where now, after just, having those 3 loading, after being certain that this patient is responding to anti-VEGF, I very much, would be offering them something that's going to be longer, be it PDS, be it, other options.
I think those are really, really good points, Lejla. I think what we have learned over the past decade is obviously each patient is different, and there are patients who need more treatment and there are patients who need less treatment. And obviously there are patients who have active disease that we need newer or more durable agents for, and that's where brolucizumab fit in, obviously because of the rare events and irreversible vision loss in some patients. It is the last option. So Lejla, you are in a university setting, difficult access to samples, difficult to get branded agents. For me, as a private practice physician, I actually have had the luck of starting most of my patients on branded drugs. Lately, there's been a lot of step therapy that we have to go through, but overall, I will initiate with a sample. If we don't have a benefit investigation done, sometime I can start right away with a branded agent, whether it's ranibizumab or aflibercept. And then, obviously, treat them monthly, and then after 3 doses or so, try to extend and then see how the disease activity looks like. Lejla, is that what you are doing too? Are you still loading and are you still doing treat and extend?
Exactly same paradigm. I'm treating for 3 doses, and then after that, extending. So really treat extend approach, very much so. And I like to, after doing a full assessment, I tend to just bring them in for injection visits with OCTs. OCT helps me, understand what the disease activities is and whether they are responding to the therapy. And then I tend to reassess them every 3rd, actually 4th injection.
So you don't do exams every time. So how does that change when you have a patient with persistent disease with monthly injection and using brolucizumab? You are doing an exam every time on brolucizumab patients, right?
That is correct. That is a great point. Because of the concern of inflammation, and with brolucizumab, and that's more likely than other drugs, those patients are actually examined on a monthly basis. I do not use it as often. For that reason, because that concern, not for the exam, but just concern inflammation itself. But yes, those patients definitely need to be examined.
I think those are great points. And Joe, I know just like Lejla, you use brolucizumab as your last option in patients who have active disease. Do you manage them any differently than what Lejla said?
Arshad, I actually do manage them a little bit different. I think because I do have patients on other medications that may come in for a direct injection. So I don't do direct injections on my brolucizumab patients. I will look at them. I will try to pick up early signs and symptoms of inflammation. And if I'm concerned about something, I will get a wide field fluorescein angiogram, just trying to pick up something early. What I don't do is bring them in monthly. I don't do a loading dose on these individuals. If these individuals could not extend beyond 6 weeks, that's where my treatment starts, and then I'm trying to extend from that point on. So I rapidly try to extend the patients as long as they have complete resolution of fluid, and try to figure out where that point of a fluid actually returns, but I do see them in between. We also call these patients early on, a couple of weeks later, just to make sure that they're doing okay. And it's a courtesy call. I don't think it adds much to the patient's management, because individuals can still develop inflammation up to a month following the injection. It's a little bit different from an endophthalmitis, which we normally see in the first week following the injection. I think the most important thing is to discuss with the patients about the signs and symptoms. They all leave my office with a sheet of paper saying if you have pain, redness, floaters, decrease in vision, or light sensitivity, to call. And the one great thing about these patients is that these are treatment experienced individuals. So if they have any problems, they should know, because they know what it feels like to have it, or what they should be feeling from previous injections.
Great. No, I agree. And I think, that's why this episode, the series is called Art of Drug Choice, because we have to use, the data, we have to use our experience, and then we have to use available treatment options for our patients. So in terms of PDS, Joe, how do you plan to use PDS? Obviously, we covered some of that in earlier episodes, but where in your decision tree will PDS fit in now that is FDA approved?
So PDS, I would definitely consider those individuals that are high flyers, those that are requiring 4, 6, even 8-week injections. I think the most important thing would be patient selection. These will typically be some of our more healthier patients without that does not have a significant amount of medical problems, considering that this does require going to surgery, and those individuals that have required a long-term suppression of anti-VEGF. I think that the most important thing is to try who may not be the greatest candidate for this device. I think I want to stay away from individuals that have maybe ocular surface disease, if they have rosacea or blepharitis, or history of scleritis, or even a history of prior globe surgery, such as filtering glaucoma procedures, or even a scleral buckle. For my older patients, obviously, I'm always concerned. So I do not want to take 90-year-old grandma to surgery for this. So for her, I probably would think about a longer acting intravitreal injection. There was a 3-fold increase in endophthalmitis in the trials. That basically is a 2% infection rate, and that's compared to other injections. And so you have to be aware of that. I think it's more, most of those patients developed infections because of the retraction of the conjunctiva. I think it becomes critical not just to monitor for disease activity, but you also have to monitor for the device activity to make sure that there's no problem. So that you do see a problem, you can rectify that early, so you don't have to take that person, you don't expose them to endophthalmitis, and take the person back to surgery earlier to just fix the tissue over the bleb. But I do think that all these things are interesting. I think that we are addressing the burden in this country. When you look at the ASRS PAT survey, that's always one of the top things that we want to address, or that the need of the retina specialists have been, is really addressing the needs and cut down the treatment burden. So we finally have a FDA approved device. I'm very excited about it. So for some patients, I think this will be a great procedure.
No, I agree. I think for patients who have a significant need in terms of getting injections very frequently, and obviously patients who want to stretch their treatment interval, PDS is a great option. So Lejla, for you have PDS and hopefully faricimab available here very soon. If a patient can go Q16 week with faricimab, or 80% in tonight lucerna, actually 12 or 16. So 8 out of 10 are now at 3 or 4 month interval. How do you decide when to use PDS?
Yeah, no, I think that having 3 to 4 month interval injection, that is going to be amazing and ideal, because we're going to want to examine these patients regardless, to make sure that they're controlled. And I foresee, in office procedure gaining more traction with longer therapy versus a surgical approach. But I think PDS will definitely have a role in patients who are not, wanting to come in that often, or potentially are just not responding to therapies as well. I think that as we continue to advance technology in terms of home screening, such as home OCT, I think we'll also see more of a switch to surgical delivery of drugs such as PDS, because now we can combine monitoring with that. And I think that will be another shift.
I think that's a really, really good point, that if you really want to not only just decrease injection burden, but you also want to decrease visit burden. So can we just see patients every 6 months and they can be monitored? And if they need a supplemental treatment before 6 months, we can catch them and then bring it. I think that's a really, really good, good point. So Joe, question for you. What is your threshold for switching patients from one agent to another? Do you go 3 months? Do you go 6 months? What are you looking at in terms of a treatment response with any agent that you're using to see how the patient is responding, and why would you choose, let's say, aflibercept or ranibizumab or brolucizumab or even faricimab? What are you going to do when you have all these treatment options that are available? How are you going to start your patients, and what are you going to switch to?
Arshad, that's a great question. And I think we will have some issues trying to carry all these biologics in our office. So I think we have to figure out which ones we're going to use. With that being said, I think that my initial treatment regimen would probably stay the same. And that may be decided on insurance, unfortunately. We do have step edits here in Ohio, so I'm forced to use a certain agent. But after the first 3 to 4 injections, I'm always thinking of anyways switching to a different agent. So that may be another on-label therapy. It may be another monotherapy. And then after another 3 to 4 injections of that particular agent, if a patient is not responding, I'll be planting the seeds early on about switching to a third agent, probably after that, between that 6 and 12 month interval. And I wouldn't have a problem even switching, let's say, faricimab earlier in that tree. Faricimab showed a great durability in the trials where more than half these individuals, nearly half these individuals went almost 16 weeks. So that may become an early adopter for me. I can also see for ranibizumab, at least in our office, going away. If it was non-inferior to aflibercept, so we're assuming that it has the same efficacy of ranibizumab. So why would I need faricimab and ranibizumab in my clinics, particularly if we have one dose that is the same for both our diabetics and our AMD patients? That would just cut down one drug in our office, particularly from an inventory standpoint. And particularly if faricimab comes out with a silicone-free syringe, I think it makes it easier for the practice.
Great. And in terms of patients switching, Lejla, how do you communicate to your patients when you're switching an agent, or how are you going to talk to a patient when you're going to go from in-clinic treatment to a surgical treatment?
Yeah, no, I approach all my patients kind of in a sort of a, even from the get-go approach that this treatment is sort of an algorithm. We will start with this therapy, and if you're not, if not you're responding, we're going to switch. And in that algorithm, I'm very much going to offer surgical approach as well, and get them kind of used to that idea, to know that surgery is an option that is going to be longer treatment, sort of decreasing the number of visits and treatment burden related to that. And then I think with time, they really understand that, and they actually may even choose that as an option. it's very similar to like any other, I feel like, retinal disease where surgery is the treatment of choice. They may not kind of be interested in the first visit, but I think over time, as the treatment burden kind of sets in, I think they'll be more comfortable with that idea. So I think presenting it early on with the idea of that's an option, and if it really is needed option down the road, I think they'll be more comfortable with that.
I think that's really good advice, and that's what I do. I offer the different options to patients, and I say we have a surgical option that we will explore after 3 to 6 months based on your response. So thank you again, Lejla and Joe, for your expert insights and great discussions. Now we're going to go on a short break, and then we'll be back with the case in a minute. Thanks again.
Well, welcome back from the break. Thanks for joining us. I'm going to pass it on to Dr. Khanani as he presents his case.
This is an 83-year-old male diagnosed with neovascular AMD, November of 2010. And so he has been a long-standing patient of mine for over a decade. Initially, patient got treated with 8 bevacizumab injections, and he still had disease activity and couldn't be extended. So he was switched to 36 ranibizumab injections, and he received 9 injections in 2019. And he was receiving injections every 4 to 5 weeks. And over time, he had persistent fluid, so he was switched to aflibercept, and he received 19 aflibercept injections, but they were discontinued because he developed severe IOI from aflibercept, which was managed, and he was back to baseline. The patient is an infectious disease retired physician, and he didn't want to go back to aflibercept after the inflammatory episode. So then we switched back to ranibizumab, and really he would require every 4 to 6 weeks, and the disease was not controlled. He was not interested in getting injections more frequent than every 4 weeks, and he was waiting for something more durable to come along. And when brolucizumab got approved, patient was really excited to receive the drug. And of course, at that time, we were not aware of the risk of retinal vasculitis, retinal artery occlusions. Of course, we knew about the risk, high rates of intraocular inflammation. So after discussing risk and benefit, patient really wanted to start on brolucizumab, and he likes to travel too. So he didn't want to come in every 4 to 6 weeks. He wanted disease control and more durability. So patient received the first brolucizumab. You can see the OCT here 4 weeks after brolucizumab. The disease activity is well controlled. He was not injected at this visit because he's looked at the OCT. In 10 years, he has become an expert on reading OCTs, and he said, well, let's watch and see. So he came back 4 weeks later. Now it's 8 weeks post brolucizumab. You can see there's still no disease activity, and didn't get an injection at this visit. And at that time, he didn't know that more frequent injection with brolucizumab can lead to high rates of intraocular inflammation, like what we have seen recently in the Merlin study. So here we just kept observing biweekly after the 8-week visit, and then we saw some disease activity at 12 weeks. So we figured that his interval is about 10 weeks on brolucizumab, and he received second brolucizumab, came 9 weeks later, and then we kept treating him with brolucizumab, and after the 4th brolucizumab, here you can see the OCT, he received the 5th brolucizumab, and then 3 days post, he called me and said, I am having the same issue I had with the aflibercept. I can't see, the vision is cloudy. So I saw him, and he had 3+ cells in anterior chamber. There was no fibrin in the anterior chamber. And of course, the vitreous was cloudy, and we couldn't see the back, and you can see the color photo. So I offered him obviously tap and inject because there's a concern for endophthalmitis. He did not have any pain in the eye, and he being an infectious disease for the doctor, he said, I don't think it's an infection. I'm having the same thing I had with the aflibercept. This is sterile. So he actually did not want to be injected with antibiotics. So we started him on topical and PO steroids, and then we continued to follow him daily. And he was not getting worse, but he was not getting better. But then his because of all the debris and stuff, his vision started to drop. And of course, I convinced him that we need to intervene. We need to put antibiotics. We need to do a vitrectomy now because the vision has dropped to hand motion. So he underwent partial vitrectomy with intravitreal antibiotics. During the surgery, I noticed retinal hemorrhages, but there were no obvious findings of retinal vasculitis. We sent the culture. There was no growth on the culture. And then, of course, we started with topical drops and PO drops after PO steroids after the surgery. And here you can see 1 day post. Yeah, it's cloudy, but you can see the retina. He still has no fluid, and the visual acuity was improving to 2400. We got Optos images, obviously, to make sure that there's no vasculitis so that we can be more aggressive if there was vasculitis. I didn't notice any vasculitis. Then obviously he came back at 1 week, looked good. We did another FA at 2 weeks post, and now the vision is improving. And you can see again, there was no vasculitis and the retina stayed dry. 8 weeks after vitrectomy, his vision again is improving, no vasculitis. We did not treat him because there was no fluid. And so the patient has done well post vitrectomy. So then his course has been that he is back to his baseline, and now he receives ranibizumab, but after the vitrectomy, his need is less. So that's a very interesting case I wanted to share because it shows if we catch inflammation and manage it aggressively, we may be able to avoid irreversible vision loss.
Yeah, Arshad, that's a really interesting case. Thank you for sharing. I think there are kind of multiple learning points from this, and starting with, this patient clearly needed very frequent injections monthly and was not responding towards the end to dose. And then the switch to brolucizumab clearly was needed. But somebody who has history of inflammation after Eylea, like now looking retrospectively, what would your choice be here?
I think that's a really good point. We published that paper in JAMA Ophthalmology a couple of months ago, looking at patients who are prone to inflammation with brolucizumab. And one of the top reason on that analysis of database from IRIS and Komodo registry was actually history of IOI. So if I knew that, I would have never offered brolucizumab to this patient. I think that's a really good point, Lejla.
But an amazing outcome. And what do you think made a difference in terms of your treatment algorithm for this patient? Clearly, he didn't want to, proceed with vitreous, intravitreal antibiotics. It sounds like actually at the end it was really inflammation. Like what do you feel like really helped this patient? Because outcome, like really going back to 20/50 vision after being hand motion is pretty impressive.
I think that's a great question, Lejla. I think the key was I was treating him aggressively and keeping an eye on him. And I think at one point I had to go for vitrectomy, and I convinced him because there was no other way to get rid of all the inflammatory debris, as well as knowing if there's vasculitis from brolucizumab, because then you have to be, get intravitreal steroid, you have to be on PO steroids longer. Some of our colleagues do IV steroids. I don't obviously do that, but I think my goal was aggressive management, and I think we're lucky that he was able to not have irreversible vision loss, which we have seen in some cases of brolucizumab associated intraocular inflammation.
Yeah, I think your push for the vitrectomy, I think, was a necessary step, in my opinion. I think it was a wise step as well. I think that's what potentially allowed him to come back to a full recovery. So kudos to that.
So Arshad, I'm happy to know that your patient has done well, because obviously these can be very detrimental and devastating outcomes sometimes for eyes. Not everyone recovers. I do agree with early vitrectomy, particularly if you can't evaluate the retina, if the inflammatory debris is worsening or just not improving, because it gives us a better idea of what's going on. And really, patients really get antsy as well. So if I think a person has obviously endophthalmitis, I tend to be more aggressive with vitrectomy early on. I think they do have better outcomes. And I would do the same thing with inflammatory events as well, just to get a better view of the retina. The only one thing I would do different if I if I thought it was an IOI and not endophthalmitis, I may also consider either injecting something like an Ozurdex or intravitreal triaceins at the time of surgery, just to give that eye a little bit extra suppression from an inflammatory standpoint. I would probably avoid that agent going forward if it was an IOI. If it's an endophthalmitis, that's a different story. You may have some time to actually buy. Sometimes the swelling is not as recurrent sometimes following these inflammatory events, but they will recur at some point. So, trying to figure out another agent, if it was truly an IOI, I would avoid that agent, and I would probably go back to whatever agent they were stable on previously. What agent did you decide to put the patient back on, and what process or what decision process went into you choosing that particular agent?
Yeah, so, aflibercept caused inflammation, brolucizumab caused inflammation. The patient told me, he said, I make antibodies to these drugs, so let me go back to ranibizumab. So we are back to ranibizumab, but the disease activity is actually much less after the vitrectomy. And, I'm intrigued by it because, we think about not having the vitreous and the PK of the drug changes in the eye, and we actually may need to inject more often, but he's been controlled now. Before he was not controlled even with 4 to 6 weeks ranibizumab, but now he is controlled. We are back to square one. Obviously, faricimab would be a good option for this patient once it's available, but I can see some nervousness and anxiety from him about drugs, the newer drugs, because he feels like he has an immune response to it. But hopefully we'll be able to convince him to get faricimab so he doesn't have to come in as frequently as he is with ranibizumab.
And maybe even PDS would be a good one too.
I think that's a good idea. I mean, in a vitrectomized eye, we don't have data, but I don't see why it won't work. I think that's actually an excellent option if he is considering surgery. So I will have a discussion with him next time I see him. That's a really good point. Thank you again for listening to this episode. We do have the other 2 episodes available for you to listen to, and the case I presented is available on itube.net, and the other cases presented by Dr. Joe Coney and Lejla Vajzovic are also available. I want to thank Drs. Lejla Vajzovic and Dr. Joe Coney for being here, for having great discussion, and really, telling us really the art of drug choice. Thank you, Lejla, and thank you, Joe.
Thank you, Arshad. It was a pleasure to be here.
Arshad, thank you for having me. I really had a great time. Thank you very much.